Iris? Where'd you go? Might as well get started while our Grand Round speaker is freshening up. Welcome to Grand Rounds. We have a special presentation today by somebody who would ordinarily be the kind of person we would schedule, but by virtue of the fact that she's assumed an elected office of considerable prominence, it makes it special and gives us an opportunity to hear things from a perspective that, we don't necessarily ordinarily do. But before we get started, let me just make some announcements. And I don't know if it's because, we had the kind of summer recess and things have accumulated, or whether we've just had a windfall, but there's quite a few announcements about NOGAs. So Dr. Patrice A received a 4-year, $730,000 KO1 for a project dissecting the role of long-range prefrontal circuits in ELS-induced susceptibility. What is ELS? Huh? Early life stress. Okay. Christiane and Jonathan should have told me that. Christine Denny, my goodness, she hit the jackpot. She got 400,000 R56, that's a new one, from the NIA. Identification and manipulation of whole brain memory traces following age-related cognitive decline in Alzheimer's disease. A 2-year, $450,000 R21 from NIA for identification and manipulation of the neural ensembles mediating sundowning in an Alzheimer's disease mouse model. A 5-year, $3.8 million R1 from the NIH for project single-cell target-specific resolution of multiple memories across the brain. Lisa Dixon and Jennifer Humensky received a 5-year, $7.9 million R01 from the NIMH on OnTrack New York's learning healthcare system. Christina Hoven, a 5-year, $3.2 million R01 from the NIMH for project uncovering the risk I'm just saying the amounts of money, which I don't usually say to impress Patrice, who's here. Uncovering risk architecture of suicidal behaviors, a representative sample at high risk. Dan Kimmel received a 4-year, $800,000 KO8 for neural and behavioral mechanisms of abstraction in humans. Catherine Lynn Lovero, a 5-year, $900,000 KO1 from the NIMH Youth Prides implementing integrated mental health care for adolescent depression within primary care clinics of Mozambique. That sounds suspiciously like Milton Weinberg has his fingerprints on this one too. And John Mann and Priya Wickamarante received a 5-year, $1.3 million R1 from the NIMH on leveraging EHR-linked biobanks for deep phenotyping. So that's really extraordinary, and it's never easy to get NIH grants, but particularly now, so congratulations to everybody. Also, we had some honors received by some of our trainees. Ryan Dasuma Johnson. Ryan received he was selected as a recipient of the ACAP Educational Outreach Program for General Psychiatry residents. And Phil Muskin was named the recipient of the Academy of Consultation Liaison Psychiatry's Eleanor and Thomas Hackett Award. This is the Academy's highest lifetime achievement award. So congratulations to both of them also. Here's Ryan's right here, and we missed you at dinner last night. Check your email. Is Phil Muskin here? Okay, we'll tell him we outed him here. So, as I said, we've got really a wonderful Grand Round speaker in terms of somebody who's one of us, being a physician, psychiatrist, but has sort of ascended to an important political office in the ultimate self-sacrificing gesture. Dr. Patrice Harris hails from West Virginia, and she was educated there at the undergraduate level, where she received a bachelor's degree in psychology, then she received a master's degree in psychology, then she received a medical degree, all from West Virginia. So do you root for the Mountaineers or the Thundering Herd? Mountaineers. Okay. When I was in college, we played the Thundering Herd. They beat us. After that, she moved south to Atlanta, where she trained in general psychiatry, then child psychiatry at Emory. She was also a chief resident. And she proceeded afterwards to do a forensic fellowship. And she's had, in addition to a career where she was clinically active in serving a number of different populations in need, she also had a career path which really distinguished itself for service, for public service. But then she took a turn for the sort of political organizational side, which is something we don't necessarily go to a medical school or graduate school for, but increasingly have found how important it is, but we don't necessarily have the appetite or the skill set. But in Patrice's case, she did, and she moved through various roles, such as being head of mental health for, what county, DeKalb? Fulton County in Georgia, and then assumed various roles, both locally, then within the APA, and then within the AMA, and then this past June was inaugurated as the president of the American Medical Association, so that's quite an achievement. But the thing that really impressed me, I think, most in reading through her bios and CVs and everything was what's listed as a governing theme in her professional life, which is a passion to improve the lives of children and service to others. And it's nice to see people in high places who think like that. So, Patrice, we're going to look forward to what you have to say, but I know you've read this book hundreds of times and memorized every word of it. This is Shrinks, The Untold Story of Psychiatry, but just in case, I wanted to have a commemorative copy, so I'm going to inscribe it and give it to you. And if you're not interested, because you know it all, it's better than Ambien. Please welcome Dr. Patrice Harris. So we go at 12:30.
12:30? Okay, great. Hello, everyone. Certainly my honor to be with you here today. I'm going to go through my leadership journey, my work at the AMA, how it connects with psychiatry in general, and really connects to most of the issues that I bet you many in this room care about today. And then I think I want to certainly leave ample time for question and answer, because I believe in learning opportunities with dialogue, evidence-based, fair-minded dialogue, respectful dialogue, and question and answer, so I'm happy to do that today. Thank you, Dr. Liebman, for the wonderful hospitality, and thank you all who joined me last night for dinner. My flight was a little late, but certainly I arrived. And I went back to my room last night and jotted down, by the way, I'm not going to out anyone or attribute any of the conversation to anyone in particular, but I went back to the room and jotted down some of the issues that we discussed last night at dinner. And even in my presentation today, I won't get to all of the work that we are doing at the AMA, and it includes some of the work that we discussed last night. But I just want you to know, again, the dinner conversation and my life as an AMA president and all of the issues that we have to contribute, that we have to tackle today. So we talked about sustainable funding last night. We talked about that in the context of grants. Grants are wonderful, right? They help us advance science. They help us advance process. They help us advance best practices. But grants are inherently time limited. And what we need to think about, particularly when it comes to mental health, is sustainable funding. An infrastructure where we don't careen from crisis to crisis and rely on grants. So we didn't solve the problem last night, but we raised the issue, and we need to continue our work on sustainable funding and long-term infrastructure, again, particularly for mental health disorders, which includes substance use disorders. We talked about healthcare financing. Now, Jeff just said, we don't go to medical school to sort of get into politics. I think he's probably right. Most of us did not go to medical school to get into politics, But I would imagine most of us went to medical school. We may not have appreciated this to advocate and help our patients. And to do that, we certainly have to get out of our silos of our offices. Folks are talking about beyond the walls. But we don't talk a lot about healthcare financing, and we do think a lot about that at the AMA. I was just meeting with someone who said that they were glad to see the AMA broaden its vision and not just worry about or protect the interest of private practice. And I would say part of that, Nidus, is true, but part of that is it is important to protect our practices, whether they be in a large hospital system, a large academic medical system, or solo ones and twosy private practice, which I did for the majority of my career. So certainly it is not the only thing we should be doing, but the AMA, along with partners, should be thinking about how we protect our ability to see our patients and practice medicine. We talked last night about being a good community partner. So I'm going to make a couple of assumptions, but one thing I know for sure, at the AMA, we are blessed with financial resources. We certainly have human capital, we have talent, but at the AMA, we do have financial resources. And I think, now this is my personal opinion, that organizations that have resources should partner with community-based organizations or other organizations that don't have resources. And whether or not you think that's your obligation or not, that's up for debate. But I think should be a commitment to partnering, those who have high resources to partner with those who have low resources in our community. And the AMA actually doesn't want to just talk about that. We want to walk that walk. And so while I can't announce it today, I can tell you that we are exploring opportunities in Chicago, because that's where our headquarters is, and partnering with communities, low-resource communities in Chicago, because we really want to be an organization that walks the talk. So we can talk more about that. I don't have any specific announcements, but I can let you know that we are working on that, and there will be announcements forthcoming. And so I would say, I said this in Atlanta, I trained at Emory. Emory has high resources. Absolutely should be committed to being a good partner in Atlanta, and is. Columbia should. Everyone, I believe, who has the resources should figure out a way to partner, and not out of tax obligations. We all know community benefit, and that gets to the hospitals, but really is embedded into the DNA of the core of your organization. We talked about workforce diversity last night. And I will say a little bit more, but I mentioned that as one of the three themes that I would like to amplify during my year as president of the AMA. But how do we get there? We have to be intentional to get there. These problems won't solve themselves on their own. They won't work themselves out without some intentionality. So we talked about that last night. We talked about burnout last night. The AMA is very involved. I had several slides on our work in burnout. Happy to chat with you a little bit about that, but we have to have conversations about burnout and what is burnout and how is burnout different from depression. And I know someone's doing work on anxiety, which is an under-investigated area. But certainly burnout is a huge problem today that we are facing. Now, the AMA is facing this in one of our three broad areas, but I won't drill down into some of our work, but happy to answer questions on that. We talked about research to practice, all the wonderful work that academic institutions do every day, discoveries. How do we get that to the community? How do we get that to practice? Important area of conversation. And we talked a little bit about childhood trauma, which again is one of the areas that I plan to highlight. We talked about team-based care. Yes, we did talk about Medicare for all, and the AMA's position on that, and understanding of that. I won't talk about that in my slides, but happy to answer questions about that. We talked about feel-good legislation, or let me just say, I talked about feel-good legislation. Policy, legislation, regulation that makes us feel good, but doesn't actually solve problems, okay? So we talked about that. Talked a little bit about innovation and technology. The AMA is very involved in that space. So let me tell you a little bit about, well, I'll save that. So I'm going to talk again about the work we're doing at the AMA, my journey to leadership, and how it all connects as we shape the future of healthcare. So I was born, this was a photo taken at my inauguration on June 11th, just this past year. I was born and raised in Bluefield, West Virginia. Who knows West Virginia or even Bluefield? Okay, oh, very good. Small town in West Virginia. My father worked on the railroad and my mother taught school. And I knew, though, that I wanted to be a physician since I was in the 8th grade. Who was my role model? And I know I share this with someone else in the room. And okay, the younger folks in the room are going to have to Google this, but that's okay. I'll give you a little bit of context. My role model was Marcus Welby, MD. Marcus Welby was a fictional TV family physician, came into our homes every week. And what I liked about Marcus Welby was that he not only cared for his patients inside the exam room, he cared about his patients outside the exam room. Now, I am told I can go back and get the full set on Amazon, source of everything we need. Maybe not. But I've gone back and looked at a couple of clips. Now, let's just be candid. Remember, this was the late 60s and 70s. I am showing my age here. And it was before HIPAA, as Jeff said last night. And he was probably a little bit inappropriate when it came to boundaries, of course, that of course we care a lot about in psychiatry and psychology and mental health. But the broader contours of what attracted me to Dr. Welby and a potential career in medicine was that opportunity to have a platform outside of the exam room. I knew that then, don't know why, 8th grade. But I said, physicians have this wonderful opportunity to have a platform. Now, who knew so many years later that I would be the president of the AMA and have this wonderful platform to speak from, and I'm so very excited. It's certainly an honor for me to be the first African-American woman president at the AMA as well and make that history. But I did not have an easy path to medical school. In fact, when I went to West Virginia University as an undergraduate, I didn't know what to major in. And back then, we were sent a paper catalog. And I remember pouring through the catalog and thinking, what the heck do you major in if you want to become a doctor? Because, they didn't talk about that on Marcus Welby. So I was looking through the catalog and I saw medical technology. It was the only major that had medical in the title. So I figured that must be what you major in if you want to be a physician. And as you all smart people know, it was not, but I got to WVU and I said, sitting at the microscope, okay, is this it? No, I don't think it is. I went to my advisor a couple of times and was confused, didn't know what to do. And my advisor said, well, perhaps you should be a nurse. Now, I know we have wonderful nurses in the room. Nurses are critical care part of the healthcare team, but that's not what I wanted to be. And so, candidly, I became a little bit discouraged. Did some other things, long story short. Actually worked for the university for several years on diversity, the university being more inclusive. But ultimately, and Jeff, you mentioned politics, I did not like university politics, right? So even my short time there, I was involved in university politics. I said, I want to get away from politics. I'm going to medical school. So I did apply to West Virginia and did get in and went to Atlanta to do my residency. So at the end of my residency, I went to Psychiatrist Day at the legislature. I'm standing at the rope line waiting to meet my particular senator. Public, everyone's standing at the rope line waiting to meet their own legislators. And I overheard my neighbor, someone standing next to me, who I think, I don't recall, I repressed that memory, was, I think, holding themselves out to be a naturopath, whatever that was and whatever that meant to him at the time. But the issue was he made a ridiculous claim about some herb or some pill or something's ability to cure cancer. And I had my aha moment at that time in knowing how important it was for physicians to be in the halls of Congress at the federal level, but the state level, in regulators' offices, because decisions are being made every day, sometimes every minute, that impact our ability to take care of patients. And so for a couple of years, I actually was a full-time lobbyist at the Georgia General Assembly. We're down there full-time, 3 months, so I was able to still practice. And then I ended up lobbying for a group that worked on behalf of abused and neglected children, again, weaving in my passion for children. And then I said, you know what, if this is great, but I really want to go back full-time to the practice of medicine. But of course, I, again, knew the importance of organized medicine, and so I was involved at the APA, became a delegate to the AMA, and of course, worked my way up through the AMA over 20 years or so, and was elected president-elect last year. And the other wonderful opportunity I've had is to chair the AMA's opioid task force since its inception in 2014. I do want to say one more thing about history. For the first time at the American Medical Association, we have 3 women who are, we call the presidents of the AMA. So you see Dr. Barbara McEnany in the dark purple. She's an oncologist from New Mexico. She's, at this point, is immediate past president. I, of course, am president, and Dr. Sue Bailey, who's a pediatric allergist from Fort Worth, is the president-elect. So what a wonderful time to be at the AMA and to be a part of history-making at the AMA. I also like to show this slide, at least from my vantage point. It's not very focused here, but this is the current board of the AMA. I know many people have in their minds who they think the leadership of the AMA is and what the AMA stands for, and I hope, again, to educate you on some of the issues we're looking at today. But here are the current board members of the AMA. You see, pretty diverse. There are 5 African Americans on this board. Our chair, Dr. Jesse Ehrenfeld, is the first openly LGBTQ member. He is our current chair of the board. So you can see we have a diverse board, and I'm very proud of that. And not only in diversity as far as gender, race, and ethnicity, that's important, but also in diversity of thought and opinion. And I think any organization who is a strong organization values diversity, and again, not just numbers of women and African Americans, but values diversity of thought and opinion, and that value is embedded into the work of its organization. And that's where we are headed. I am not saying the AMA is a perfect organization or has been perfect. Many of you know that many years ago, the AMA did not allow African American physicians to be a part of the AMA.
Patrice?
Yes.
Well, in the context of diversity, is
Yes.
the medical specialty that people are in, is that a consideration?
The House of Delegates, so let me tell you, we are elected by the AMA House of Delegates, and the House of Delegates is a body made up of representatives from every state and every specialty in this country, and along with some special sections. So there's the medical student section, the resident section, the young physicians, the minority affairs section, the women, and so all of those folks come together twice a year and they elect this body. Now, they elect each of us on the breadth and depth of our experience and our past work. There is a diversity of specialties, but I don't think they pick by specialties. But the smart organizations want diversity, again, of everything. And so let me use this pointer. Let's see who we have. This is me. Psychiatry, pediatric allergy, radiology. Here's our medical student, Sarah. Jack is a dermatologist from California. Why am I blanking? Willie is a urologist, cardiologist, family physician, internal medicine. Bobby is ENT, Jerry, family medicine. Sandra from Georgia, internal medicine. I am blanking. Anesthesiology, OBGYN, plastic surgery, oncology, ENT, and Jesse's anesthesia. So pretty diverse. And I do think the House of Delegates considers that, Jeff, when they vote for these folks on the board. So I told you about the AMA and the House of Delegates, but of course the AMA is so much more than just our policy making. How many of you, well, you don't have to answer this, but JAMA, You receive your JAMA, that's our research and education. That's a way we connect with physicians. CPT, for those of you who don't know, the AMA leads on CPT. And so that is owned by the American Medical Association. So that's a part of our business practice and tools. Of course, our members are a critical piece of the work that we do. And of course, what people see the most is advocacy, right? That's what makes the headlines. I just testified before Congress on Monday, last Monday. It's a blur on the crisis in maternal mortality and morbidity. For those of you who don't know, and I know you know this in New York, because Dr. Elizabeth Howell, I think she's at Sinai, was one of those who testified with me, who talked about in New York for African-American women. So first of all, in general, African-American women are 3 to 4 times more likely to die around childbirth and being a mom. Native American women are 3 times more likely. And in New York, there are quite amount of disparities in your hospitals. In some New York hospitals, the rate is 8 times others. So that gets into the issue of health equity and health disparities, which we're working on right now. But again, I was just on my travels. I was just at the Congressional Black Caucus legislative weekend where I testified on gun violence and violence. I talked about the importance of church and spirituality and mental health. Those of you in the room may know, and happy to hear your experiences, but I've been to church, an African-American church, where, and this was years ago, there has certainly been evolution, but that was a great panel, by the way, but where I heard the pastor say, if you have God in your life, you don't need a psychiatrist. But I've never heard anyone in the faith community say, if you have God in your life, you don't need your cardiologist, your endocrinologist, you don't need all of that. So we have to really work on that. So that was a conversation that we had in that panel at the CBC, standing room only, a lot of conversation around that, of course, and that has led, as you all know, to significant stigma, particularly in communities of color, when it comes to seeking treatment for us. And so that gap is a huge gap, and so advocacy on that. Hopefully, you've heard all of our work on gun violence. I don't have that slide. We have a lot of policy on gun violence. You may have seen my quotes that hatred is not a mental illness. And so we do a lot of advocacy work on that. I've already talked about faith. You've hopefully seen our work on DACA. You've seen our work on the North Dakota gag laws, I hope, where the laws in North Dakota compelled physicians to talk to their patients about treatment alternatives that are not science-based and not evidence-based. So the AMA we sued on behalf of that. And of course, we sued on behalf of the Affordable Care Act. So very involved in advocacy. On the foundation of that, of course, is our innovation ecosystem, and I'll talk a little bit more about that. So the AMA is engaged in many ways with physicians, and of course, as physicians, we work on behalf of our patients. I already talked to you about the House of Delegates, but you can see some other policy over the years put forth by the House of Delegates on many public health issues. In fact, when I go around the country and I talk to folks and they say, does AMA have a policy on? I don't even let them finish the sentence. I answer yes, because we pass a lot of policy in 2 meetings a year. So I can assure you that we have policy on everything. If you ever are curious and want to know our policy on a particular issue, go to our website, then go to Policy Finder, type in a few keywords, and you can learn what the AMA's policy is on whatever topic. But certainly very involved. Now, Jeff and I were talking last night. Policy is just the first step. The next step is advocacy, and the AMA can advocate, but it is up to each one of us, and now I'm stepping out a little bit beyond my role as president. Voting and passing policy is the first step. Accountability is the next step. And so folks have to hold those who set laws, make laws, and set policy accountable. That's a little bit of politics, but that is my personal thought on that, and I'm happy to chat more about that. But this is the room of folks that votes and sets policy and also elects the leadership of the AMA. We do say that we are the physician's powerful ally. We want to present physicians with a united voice. There will be times when we disagree. I can tell you that perhaps psychiatry or issues in psychiatry don't always agree or not always in total alignment with the AMA, but that's what democracy is about, is it not? I mean, it's about coming to the table, the ability to come to the table freely and openly and debate policy, again, based on the science. But I can tell you, when we go to Congress or here in New York, the New York General Assembly, I think it's the New York State General Assembly, when physicians are unified, there's a greater opportunity to affect change. I just have to tell you, that's just the way that works. But we want to remove the obstacles that interfere with patient care. We all know the burden of electronic health records. We all know the burden of prior authorization. All of the obstacles, again, this law in New Mexico that said that physicians, of course, in New Mexico had to tell their patients that the abortion medication could be reversed. Those are the obstacles that the AMA works toward removing so that there is no interference in patient care. On the side of confronting our greatest public health challenges, we've decided to start with two, and then, of course, the opioid issue bubbled up. But the two issues we are starting with are prediabetes and hypertension. And again, on the innovation space, we want to drive, first of all, how we train the next generation of physicians. I don't know, we didn't chat about this last night, but traditionally, what has it been? 2 years preclinical, 2 years clinical. Should we look at that again? We really haven't changed the way we educate physicians since the Flexner report. And so we really need to, is it about the years in medical school, or is it about competencies? So is it about time in chair, or is it about measuring competencies? Of course, that means we'd all have to agree on what the competencies are. And then let's say medical schools revolutionized and they said it is competencies. And let's say you finished medical school in 3.5 years. What do we do on the graduate medical education side? Because we start right in July or around July, June or July every year, right? So what if you were able to demonstrate your competencies in January? What do you do from January to July? And so we actually, at the AMA, are looking at this and spurring innovation in how we train the next generation of physicians. Prior authorization, huge burden. We talked about this last night. Based on, here's data from the studies that we have done. And the most compelling study, at least from now all of this is compelling to us, and actually this is not news to you in this audience. You live this every day. But what we have to do is make the case external to medicine, and that's where advocacy comes in. What's been compelling to business leaders is when we say for every hour we spend taking care of patients, we spend 2 hours on administrative burden. For every hour we take care of patients, we spend 2 hours on administrative burden. That is compelling. Because I can tell you about burnout and all of these issues, and you know this because you probably heard this. When we first started to raise these issues, what was the response? Oh, those whiny, privileged, entitled physicians. They have a great life, decent money, they're all driving Mercedes. What do they have to complain about? And so we have had the opportunity to do the work and do the research to put some data. Now, we knew that we were not just whiny physicians. We knew this was impacting our health regarding burnout and impacting patient care. It was very helpful to have this data so that we can show. And so we've done a lot of work to right-size prior authorization. Please go to fixpriorauth.org, not now, but when you get a chance, because you all know that the data is one thing, but the narratives are another. And so we have patients telling their stories on this website about how they have been impacted, how care has been delayed because of prior authorization. So when you get a moment, please go, and we're always collecting those stories. Because I won't name the insurer, but I was just, again, the travels of the AMA president, I was just speaking before an audience of a commercial company. And they really do believe that prior authorization saves money. And they really do believe that their employers, the folks who are purchasing through them, want them to do prior authorization. Now, and what we need to do, and what I said, well, let's go back to those employers and educate them that actually there's a delay in care here, and that patients are actually being harmed. Now, I'm sure there's always the one or two egregious examples, because we have to be honest about this. I talk about confronting today's health crises with three main points: intellectual honesty, context, and the science and the data. So yes, there probably are egregious one or two minority, I would guess, who are not doing a great job. And so at the AMA, we've talked about, how about gold carding the physicians? If I am treating patients with ADHD and I get my medications approved 99% of the time, how about giving me a gold card, something like TSA PreCheck, right? You already have the data. You have the data. It's your data. I don't have it. You have the data that 99% of my prior auths have been approved. So how about I get a gold card so I don't have to go through that over and over again? So we've developed some principles with actually AHIP and the Blue Cross Blue Shield Association of America. So, and that's the first bullet there. We also are pushing state legislation. You know, it's great when payers volunteer to do something, but sometimes you need legislation. There's some teeth. And so several states are really passing legislation to require that states eliminate prior authorization, or at least right-size it. I could say we're not advocating for total elimination, but right-sizing prior authorization. And I think we all know about step therapy. Well, you have to fail. Now just think, fail first if you really think and push back. And on our day-to-day, we're taking care of our patients. But just think what you're saying to patients when you say, well, you need to fail on this medication before you can get the next medication. So that's built into our system, having our patients fail. What's wrong with that picture? And that's the advocacy work that we have to do. And again, we have the resources on fixpriorauth.org, fixpriorauth.org. I just want to go back to this 36% of physicians have staff who work exclusively on prior authorization. So if we talk about really saving dollars, and we could find other great things for the wonderful staff to do, but just think how inefficient that is. Again, in our survey, we ask about impact on clinical outcomes, and you see the results regarding care delays, waiting 1 business day, 3 business days. I've waited longer. And by the way, you can let me know automation is not helping. And I will tell you, sometimes the commercial payers said, well, if we just automate the process, maybe if you go on the computer again for another click or two, of all the, as Steve Stack, our former president, used to say, death by 1,000 clicks. So if we do 1,002 clicks, right, this will fix the problem. So it's more than automation. Certainly automation helps, but it's more than automation. As you can see, the big red box is 28% in this survey reported that prior authorizations have led to a serious adverse incident. So it's not about inconvenience. And let me get off on one of my soapboxes here about inconvenience. I may come back to it later, but inconvenience to me, let's say I could wait a day. I go to my physician and he says, this has to be prior auth. Can you come back tomorrow? I have a car. I have the ability to get off from work. I manage my schedule. I control my schedule. So it may be inconvenient for me, but it is more than inconvenient for someone who doesn't have a car. Now, don't forget I live in Georgia. We don't have the great public transportation, but even here on the subways cost money, right? And if you have the additional time off from work, and perhaps you have to arrange childcare. So sometimes when people talk about inconvenience, I don't think they appreciate the depth and breadth of what inconvenience means to the diversity of the patients that we see. We were loud and proud on defending Title X, and that was again about our ability, physicians' ability to speak to our patients about all the appropriate treatment alternatives without any government interference. So this Title X regulation and the 2 North Dakota laws were about physician gag laws. And as you know, you will find no more staunch defender of physicians' ability for free speech than the AMA, and certainly probably everyone in this room. So that has been the work that we've done. We did file an amicus on Texas v. Azar. As you know, there are attempts to roll back the progress we've made with the Affordable Care Act. The AMA was supportive of the Affordable Care Act when it first came out, and certainly we filed the amicus brief in opposition to rolling back the protections. And we know so many people were able to gain coverage, and for us in this room, of course, you live in New York, I live in Georgia, we did not expand Medicaid. So many people across this country have been able to have improved access to mental health treatment because of Medicaid. So critically important. Prescription drug pricing, our truthnrx.org microsite talks about all of the work that we've done on that. For us, our current issue is we need transparency. It's hard to know what's costing what. We used to have this slide, a Tangled web slide with the PBMs and the purchasers and the insurance companies. It's really hard to know how much medications really cost, and it really is hard to solve a problem if you can't even identify the problem. So we've been an advocate for more transparency in that whole process so that we can then have an informed database conversation about tactics and strategies to improve our issues around prescription drug pricing. These are some of the other issues that, there's a pay for delay. You get a generic and maybe there's an opportunity to delay the new generic on the market for another couple of years. That happens from time to time if you didn't know that. And just a lot of other issues around the whole supply chain transparency. We have a lot of policy on that. As I mentioned, and you know this, it's about the human and the financial toll of chronic disease, heart disease, stroke, and diabetes, again, the top 10. And so and if you look at the money that we spend on these chronic diseases, so again, we've partnered with the American Heart Association. So you don't have to admit this, but how many of you have gone to see your physician and you got your blood pressure taken, you're rushing in because you're late, you're in the seat, they may ask you to remove, but they may just take it over. Me, I'm always cold, so my 5 layers of clothing, and one arm might be up here and another arm, and it's the machine, and has that machine been validated, and what do we know about that? And so we have been working really hard, number one, to encourage physicians and systems to, first of all, measure accurately, right? And then after that, make sure that folks are treated to target, because we know that so many folks in this country are walking around, first of all, don't know they have hypertension. And then those who do know hypertension aren't treated to target. Another opportunity for health equity, what may work in communities of color may not work, the same medications may not work. And so we're working a lot on that in the health equity space. We also are looking at pre-diabetes. So we decided, okay, people are in the diabetes space, but is there an opportunity to prevent folks from developing type 2 diabetes? And that's why we have gone and worked with the American Diabetes Association. Folks can go, it's a public website, doihaveprediabetes.org. In fact, I was listening to the radio the other day and there was a commercial. It said, put up your hands. If you have this risk factor, raise 1 finger. If you have another, if you're age, if you're African American, raise 3. If you have 5 fingers, go to your doctor and talk about these risk factors. And so again, very involved in that space because it saves money, but more importantly, we know the effects of diabetes on people in this country. As I always say, there are people behind these data points. So I'm going to see if this worked. This is a commercial that we worked on with the Ad Council about our prediabetes work.
1 in 3 adults has prediabetes. 1 in 3. That means it could be you, your favorite brother, your other brother, you, your football buddy, your football buddy, you, the boss's boss. If 1 in 3 adults has prediabetes, that means it could be you, your barber, your barber's barber,
Nice work. Thanks.
You, your plumber,
Breathe right into your foot.
your plumber's masseuse.
Yes.
You, your dog walker,
On your left.
your cat jogger. Or you, your co-pilot, your co-pilot's co-pilot. While 1 in 3 adults has prediabetes, with early diagnosis, prediabetes can be reversed. Take the risk test at doihaveprediabetes.org to know where you stand.
So as you know, we were deliberate and intentional in that to make sure that we had diversity in this commercial. We think about that a lot at the AMA. It's not enough, as I said earlier, to talk about it. We have to make sure that we are intentional about the work. And we wanted to put a little bit of humor into it. Didn't hear a lot of laughter, but okay. Maybe I'll tell a joke in a second. Many of you, of course, know that, again, the foundation of all the work that we do is our Code of Medical Ethics. And we have a whole council that looks at that and develops our policies going forward and opinions regarding ethics. But again, written into the AMA's Code of Ethics is the respect for human dignity and rights. Maybe we'll have a little opportunity to talk about the recent opinion piece that was in the Wall Street Journal. And stay tuned. Actually, I've been editing my response to that piece. And it will be out in our channels probably later on today. So again, when we have these components built into the DNA of the Code of Medical Ethics of our organization, it's very important that we expand upon those. And so we are embarking upon what I call our Health Equity 2.0 space. We just hired our first Chief Health Equity Officer. We stole her from New York. She worked in the Department of Public Health. I might not have the exact name. Dr. Aletha Maybank. I know she said she's worked with some, maybe not in this department, but has worked with some folks at Columbia. And we're very excited as she is developing and creating the AMA Center for Health Equity. So stay tuned for our work on that. She just started a couple of months ago. We're trying not to overwhelm her. But also, I told her and the other leaders, Aletha is not the savior. And this is the point. Your diversity and inclusion officer, may not have the title right here at Columbia, is not the savior. That person should not be looked to whenever there's a problem. We all should own, and be accountable for diversity and inclusion and equity. And by the way, there are reasons all three of those terms are used. Diversity is almost about checkboxing, or it has become that. Probably not the original intention. So you have 10% women, 50% women, 10% Latinx, 2% African American men. We need those numbers, we need that data. But if you're just checking boxes, then you are, I was just talking to the dean about this, meeting the metric, if that's your metric, but missing the point. And we do a lot of that, meeting the target, meeting the metric, but missing the point. So once you get those folks at your institution, what do you do to demonstrate that they are valued, as everyone is valued? And by the way, it's not a us versus them. It's not I'm valued and you're not. It's we're both valued. We're all valued. But that has to be a culture change, and you have to make sure that you're just not getting top-notch talent, which you all get here at Columbia, but then when they get here, there's not an environment that sustains that person, because you could have 10% African-American men, but is it a revolving door? Again, that might be meeting the metric. The metric was 10, you got 10, but it's been 10 different people in the last 10 years. And so what's wrong with that picture? So again, health equity and then inclusion, and then for what? Why is this important? It's important to get us to health equity. So we have to have all of those the conversations about all of those, and make sure the conversations include all three of those points. But so in our policy and in our advocacy and tools that we are developing, and again, we're excited about Aletha, but as I keep saying, and even every time I say that, though, I say, Aletha, you need to do this. Aletha, you need to do that. So I have to be careful that I don't go back into my old habits again. She is not the savior, but we do want her to lead the AMA in our own internal commitment to health equity, and then we can talk to others about it. I don't know how many of you heard, I'm from the South, and my grandmother used to say, you have to have your own house in order, right, before you tell others what they should or should not be doing. And so that's what we are doing at the AMA. As I said, we have that history. And by the way, I didn't complete that story. In 2008, at the time, immediate past president, Dr. Ron Davis, who unfortunately years later succumbed to pancreatic cancer, but he went to the National Medical Association meeting, the National Medical Association for African American Physicians, who formed because they couldn't join the AMA. But he went to a meeting in Atlanta, in fact, and apologized. Apologized, and you can find the specific wording of that apology to African American physicians. Because realizing, again, it wasn't about just the membership. What we don't know is, did that affect health disparities? The fact that the AMA did not allow membership, did that have any impact on patients and patient care in this country? And so, as he said, that apology was not the end, but it was just the start of more work. And of course, we continue on that work at the AMA. And as I've said, I am so proud and honored and privileged to be the first African-American woman, but I don't want to be just the checkbox. And of course, we're not at the AMA. I can guarantee you that if I have anything to do with it, and I'm really excited about Aletha. So I teased her, I said, okay, you have to make sure I'm not the checkbox. And so that's where we're moving at the AMA. This slide you all know, I've talked to several people last night and today with the deans about we need to find another word for social determinants of health. Actually, nowadays, I know you are an informed audience, but I actually now just use determinants of health because there is a patina to social, sometimes a negative connotation. And so it is whether or not you have access to care. It is whether or not you live within easy distance, safe distance, whatever that means, and can get to a hospital when you have an emergency. But it is all of these other factors, and they're all determinants of health. And it's not about social, whatever that means. So I know it's in our language, but actually I am dropping social. This is not a big announcement, and say that on Twitter, but I just think we need to make sure that we look at these issues equitably. And so, but you all know this slide, and this is the work that we have to do. And I want to say something about individual behavior, which I think I alluded to at the beginning of the talk. The choices you make are based on the choices you have. And so if we tell our patients, you really need to increase your physical activity. And I remember saying this, and you don't have to join and have an expensive gym membership. Just take a walk around your neighborhood. But if your neighborhood doesn't have sidewalks, lighting, safe, that's not so easy. Eat more fruits and vegetables. But if you live in a food desert, that's very difficult. So when we talk about individual behaviors, absolutely. Exercise, smoking. I did not have, although I do eat a burger every now and then, I did not have the filet mignon last night, but I will from time to time. Certainly those behaviors impact our health, but I have the privilege of making choices that many don't have. And so my only point is, let's be careful about blaming and shaming when we talk about individual behavior and choices. That's my only take-home message there. When I was my inaugural address, I mentioned, again, the AMA's 3 strategic priority areas. You've seen them, but what do I want to do in this year? Now, it is a foolish organization who changes priorities every year, right? You have to have a strategic focus, and we do. Those are our 3 priorities. But again, talking about that platform that I now have, I am elevating 3 things. Number 1, the importance of mental health care into overall care. Number 2, again, you heard me talk a little bit about this, increasing the diversity of the physician workforce. And let me just stick a pin into African-American men going in the wrong direction. And to me, that is a critical area where we need an all-hands-on-deck approach right now to address that issue. And by the way, not ours alone to solve. By the way, that other 80%, not ours alone to solve, but we have voices and we have a platform. And that's the point of that. And we can build partnerships, and some of us have resources. So that's the point of that. And my third area that I wanted to amplify was the importance of childhood trauma and our work in the adverse childhood experiences. I know you see this every day in your practice. Some large percentage of the patients we treat have experienced childhood trauma. I'm not saying they're not continuing to experience trauma, but have experienced childhood trauma. So we really have to look at this issue. We can screen for this, but then what? Another opportunity to develop systems and supports as we look at this work. And again, I think we as psychiatry significantly see the impact of this, but the cardiologists do too. There's data about the effect on cardiovascular health. And there's data regarding diabetes. So it's not just, this is certainly not just ours alone to solve. And again, fully integrating mental health. My work at Fulton County, when I was health director, I'm so excited. We were early in the game, but we renovated 2 facilities and built one from the ground up that had mental health care, public health, primary care, but we also had our housing team there because the county provided those services, our employment team there. We also had a drop-in daycare center. Not a general daycare center, but we knew that was a barrier. You come into care, or you might say, I can't go into care because I can't, it's too much. I can't get all 3 of my kids or 2 on the bus with me. And so we built a drop-in daycare center right on site. So when the mom or another child may have been the focus of the clinical visit, the other children could go to the drop-in daycare center. We also had a community garden on site. And so with our WIC program, we worked that the moms could go outside and mainly moms, sometimes dad, but mainly moms, go outside and get a bag of fresh fruits and vegetables. So I would say we really put our money where our mouths were in Fulton County and were, I think, an early model of what you can do when you really think about including that. I remember thinking, we have these moms who are coming in for WIC, and by nature, unfortunately, of the WIC appointment, WIC is Women, Infants, and Children's nutrition program, they were there for hours getting certified. So I thought, what an opportunity. They're there for hours. Let's have our behavioral health care team run some groups on stress management, on identification of any of their other mental health needs. I mean, they're there, right? And so those are some of the things that we tried to do as infrastructure and sustainable funding didn't have. But I think, if I say so myself, one of the greatest ideas in the world. So anyway, but really, really important, as we all know in this room, and I know some work is happening here at Columbia, integrating mental health care. Now, I know even in our profession, there's a little bit of push-pull on this. Some folks want to see the patient, and other folks are worried about relegating psychiatrists to consultation only. And I know there's this push-pull. I will just say that, and we can talk about this. I'm about to finish. Not either or. We can do both. We can do all. We can do more, whatever the 4 or 5 models are. So let's not have an argument about whether or not we should just be, the patient here, an individual, or consult. And I think many of you in the room who are older may know the previous argument we had about carve out or carve in. Now, at the time, there was a good reason to carve out. Jeff, you can tell me what you think about this. There was a good reason to carve out, to my understanding, because otherwise we weren't getting any funding. The consequences of that, unintended or not, were that we were set aside and seen as the other, not integral to overall health. So again, life is messy and complicated, as we were talking about last night. And this either-or dichotomy, I'm good, you're bad, we in this room can be models and help get folks out of that. Say a little bit about the opioid epidemic. I don't have to tell this room the public health crisis that we find ourselves in, multifactorial, you all know that. So what are we doing about it? And so we formed the AMA Opioid Task Force in 2014. And here are some recommendations that we recently published. And of course, we are trying to working to put into action. You've already heard me talk about prior authorization. We can't forget that pain, or the treatment of pain, or the undertreatment of pain, depending on who you talk to, but pain and appropriate pain treatment is still critical. And as we reduce the number of prescriptions, we have to make sure that our patients in pain still have access to comprehensive care. And that may be biofeedback, and that may be cognitive behavioral therapy. That may be a procedure, a neurological procedure, but it may be physical therapy. But we have to really work hard to make sure there's equitable access to those alternatives. We've been providing physicians with resources, and certainly coverage and stigma is huge. Here were our first 6 recommendations that came out in 2015, and you can go to that microsite. We have a lot of little microsites at the AMA, right? EndOpioidEpidemic.org, and learn more about that. We have state resources and specialty-specific resources on that. We have made progress, but by no means are we declaring victory. And as you all know, this epidemic has evolved, and now it's those, most of those are dying from the overdoses or illicitly manufactured fentanyl and heroin. And I do want to say this, when we talk about equity, we always have to remember, talked about AMA's history, we have to remember our country's history on this issue. Back in the 70s, when most of the people dying and using were black and brown, our country's response was incarceration. Lately, when most of the folks dying were upper middle class and middle class white Americans, our response was treatment. Now, we in this room knew about treatment back in the 70s, so that's not new to us. But I think we have to just be intellectually honest and talk about the history. And we have to make sure that we don't repeat that history. And it is about treatment. And these are medical disorders, and they're not moral failings, and they're not character flaws. And we can help with that. We know this, but we can help with that. So sometimes I feel like the language police, but when I hear anyone, and particularly some of our colleagues, using terms like drug-addicted babies, junkie or addict, I can get real specific and probably split too many hairs on this. It's substance use disorder, and I realize we've evolved on that too, so I can be gentle with that one. But we really have to look at, excuse me, the language that we use and model appropriate language for others to use as we understand this. We also have to point out the success stories. If you look in the media, it's all of the folks that are under the bridge and doing horrible things. We don't hear a lot about the success stories. And so we have some responsibility to make sure that others know that there are success stories and people can do well. And no, medication-assisted treatment is not substituting one drug for another. It is evidence-based. And so that's the work that we have to do in this room. We are laser-focused on parity right now. Parity laws have been in the books for 10 years, at least the federal parity laws, and we are nowhere near getting our commercial payers to make sure they are adhering to the parity laws. We've had some great progress. We always like to congratulate Pennsylvania. Pennsylvania, in a landmark agreement, had the 7 largest commercial insurers agree to voluntarily eliminate prior authorization for medication-assisted treatment. They also were required to have at least one of the 3 medications that we know in this room work and are evidence-based on the lowest cost-sharing tier. So we applaud Pennsylvania for that work. Of course, 15 states said, okay, we're done with the voluntary. We're writing a law that you have to make sure that you eliminate prior authorization. What is the point of delaying care for someone who has an opioid use disorder and will go out and use? Because we all know that withdrawal is not pleasant. It is not pleasant. And folks are using not to get high, as we all know in this room. We have to educate others, but to keep from having those horrible withdrawal symptoms. And so we are really calling on other states to model Pennsylvania and the other states. Just last Monday, I think, I was in DC, and we laid out our opioid roadmap, because again, it's not about just telling people what to do, we want to show them how to do it. And this is our roadmap for states to follow, and here is what we have found from 4 states that we've looked at are key to success. Vigorous state oversight and enforcement. I can tell you states that are doing this, state insurance commissioners, and remember, this is under the rubric of state health commissioners, they are finding violations. Surprise, surprise, we all knew that. By the way, most patients don't even know if their own insurance is violating parity. So there's some work we can do on that. Of course, Medicaid expansion, I've already talked about the sustainable funding. And the last thing that's very important is to evaluate policies. Since this opioid epidemic, there have been hundreds of state laws passed. Is anybody going back to see what's working and what's not working? And so that's the other issue that we highlight in this roadmap. Again, I want to get to questions, so hopefully you know our work. I talked about our work earlier in innovation and how we educate the next generation of our students. This health system science book, I don't know if you all have read that. It's a great textbook in learning a lot about what we didn't learn, many of us didn't learn in medical school. We just awarded another $15 million, again, to continue that innovation in the GME space. I'm not sure if you guys applied for one of those grants, but I'm sure you're innovating and want to hear about that. We have a great women's physician section. Of course, we're highlighting gender equity. That's our Surgeon General, Jerome Adams, is working with one of our pipeline programs. We have scholarship. We talked last night about the fact that we need to think about student loan debt. I don't have to tell some of you in this room about that, but how do we solve that problem, and how do we solve that problem in an equitable manner that makes sense? So we need to continue to have discussions on that. So I encourage you, unabashedly, unapologetically an AMA member, and encourage you to consider membership. If not membership in that, membership in your specialty or your state, so that now, I'm going to charge each of you in this room and say the least you can do is know your own legislator and give them a call every now and then and hold them accountable for issues that you care about. That's the very least I think everyone in this room should do as part of our special professional responsibility. There may be someone in this room who runs for president or runs for office. That's a pretty high bar, but do that too. But in between, please join organized medicine, and I hope you consider the American Medical Association. So thank you very much for your time today, and I think I have time for questions.
Patrice, as you were speaking, I was sort of fantasizing seeing you up on like the debate stage for presidential candidates, because the leadership that we get in academic institutions and healthcare systems is the quality. I mean, it's a very high quality. We know it. We see the talent, the experience, the ability of people. Experience in the political arena is all like happenstance. It's elections and electoral politics, and we're all subject to that. So, at any rate, I'll keep fantasizing, and maybe after your term is over, we can talk further. But let me just make 2 comments and then stop and open it up to questions. The AMA is in a position to be have the bully pulpit, the biggest platform advocating for healthcare. And it does, as you've shown, and I think much of what you've described is news to a lot of us, because we're not sort of steeped in the programs or even maybe members. You have 2 problems. One is and this is particularly for the younger people, the individuals who were trainees, early career, under whatever the age is, how do they relate to it? How do they see is this AMA is not, Marcus Welby's AMA. It's, well, I mean, that's good, but they don't even
No,
know
you're
Marcus.
right, yeah.
And then the second is all of the individual programs that are being done are wonderful and well-intentioned and successful to varying degrees, but they're one-offs at a kind of grassroots level, as opposed to being systemically driven by a federal policy. And that is really, I think, the hardest challenge. And AMA can't fix global warming. The AMA can't fix distribution of wealth. It can only do what it can do. But the first thing is you got to, it has to establish credibility so that everybody in this room who's coming into healthcare says, I need to be involved with this because they're my voice in Washington.
I agree. And my answer to that is I want you to tell me what that looks like. Because as you can see from my career, I am a joiner. So I'm the last person to ask because I just believe in it. It's in my DNA. It's not in everybody's, and there's nothing wrong with that. So what I need and what I want to hear from others is where you think we are not credible or where you think, where you would like for us to be. Now, and I always say, we can't be all things to all people. And in a democracy, you don't always have the policy that you want passed. For me, and we live in a democracy in this country, I think I still prefer that. Now, if I could be a queen, I think it would be a good idea. But the problem is when you have a queen, when that queen dies and you have the next queen, that's a danger. And so I think part of our bargain in living in a democracy is we have to appreciate the fact that we don't always, our view is not always the prevailing view. But the key is to stay in there and fight hard. That's what I believe, and I think, again, that's the bargain for living in a democracy, is we compete on the best ideas, you get the ideas out there, and you have to be willing to not win. And that was hard for me when I went to the legislature. I was crushed the first time additional funding did not pass for additional caseworkers. That was one of my signature issues I worked on when I was lobbying for that group on behalf of abused and neglected children. I went home and cried. I was crushed. And the alternative was to stay home and under the covers, but I had to go back the next day and fight for something else.
Well said. Susan, then Tom.
Hi, thank you for talking about diversity today, but one thing I noticed missing from your presentation is any mention of LGBTQ health disparities. We know there are giant disparities in the trans community in terms of access to health care, among others. So I just wondered, where is that in the AMA platform? Because it seems to me that, in addition to that, there's also intersectionality where we have, trans people of color, and that we should be paying more attention to the fact that our groups are all overlapping and that sexual and gender minorities are a big part of that too.
A very huge part of the work that we do. I'm happy to come back and do
I want to put it on your slide.
Yes, I'm happy to do. Well, and I didn't have it on here, but hopefully you've seen, or you may not have seen, our recent statement on the administration's policy regarding the LGBTQ community. So we have a lot of work, and I will put that on my site because that's we've been very engaged in that area. Yes, and we have an advisory committee to the AMA Board of Trustees. So the AMA Board of Trustees has 3 advisory committees that advise the board. That's our Council on Legislation, that's the LGBTQ Advisory Committee, and that's another, we call it our Council on Long Range Planning. So I will add that to the slides because we do a lot. Like I didn't have DACA, I didn't have all the work on immigration. We just put a letter out. By the way, I'll just say this, as you said, and to your point, and I'm happy to put it on the slide, but there is so much we do at the AMA that doesn't get noticed, and sometimes that's deliberate. Like we send a lot of letters to the administration that we don't send out to the press. We just sent a letter out about the appalling conditions in our detention centers. And so we don't do those things for press. We do those things because we're trying to make a difference up there. But fair point, and I will put that on the slides because we have a lot of work in that area. Happy to say that.
And maybe integrating more of learning about that kind of care for minority communities into medical education as well, which I know is happening, but we could probably use more of it since part of the problem is doctors treating trans patients, for example, not knowing about them.
What to do. And our current chair, Jesse Ehrenfeld, is an expert in that area, so just doing a lot of work. And in fact, at our board meeting, we had a conversation. Lisa, who's an OBGYN, said, Jesse, I need help. I had this woman come in, and of course, I live in Atlanta, and in a couple of speeches again, and I do try to tailor to the audience and can't get in, but I talked about the absolutely alarming rate of deaths with trans women of color, African-American trans women. And that is just frightening. And I have mentioned that in several presentations, so happy to make sure I note that we are active in that space.
Just before Tom asks this question, I just want to, our department has been proactive in this area largely through the expertise and awareness of some faculty, and Anke Ehrhardt particularly has sort of expanded at a organizational level, a division of gender, sexuality, and health that we've been able to innovate, service, teaching, research. What's the receptivity been within the other disciplines within the medical school and the healthcare? Is that something that when this comes to their attention, they immediately get it and, develop an interest and engagement, or is it still like kind of a voice in the wilderness?
Well, it varies, but really I was thinking when you were getting into the weeds, where often there are some of the obstacles. So the weeds are also how transgender or gay parents with kids get through the receptionists and the forms. There are two guys, somebody told me, or one actually high up here in our organization, who had with his gay partner a baby, going to the pediatrician. So here's, as you mentioned, here are all the forms. So what are you? Who is the mommy and who is the daddy? Well, I'm the daddy. We have two daddies, but I don't have this here on the form. I don't know what I could do with this insurance. So it's that level, which is really difficult to change. And then what Jeff is saying, to put an interdisciplinary team together for trans treatment in terms of surgery and hormones, et cetera, they are, I would say, Jeff, more and more we have people also of the younger physicians who want to get involved. Then there are all the insurance levels and all of that going on. But it takes time, but we have a conference every six weeks where we have providers of New York coming together on trans. And so that's, again, one of the things how you can then build bridges.
Yeah.
And the suicide rate, huge, and we see that. And actually, this was a point that was made in that panel discussion that I said at Congressional Black Caucus, because if those of you who don't know, this area in the Black church is fraught with a lot of issues, and not coming to grips with that in traditional Black churches, and not that causes suicide, but we know the increased rates of suicide for youth, LGBTQ youth, so.
Tom?
Thank you. Just a lovely presentation. Really appreciated it. I'm Tom Smith. I'm a faculty member in the department here, but I'm also the Chief Medical Officer for the New York State Office of Mental Health. So like you, I spend much of my time doing policy advocacy work, and I really got the sense from your talk that you're passionate about it, you enjoy it, and I feel the same way. You really, as a physician, it is important. I'm glad you gave that message that you can have an impact, and the physicians' voices are needed in these arenas. So appreciate that. Thank you. I want to ask you a little bit more about the parity work. We're making a big push in New York to enforce parity in the next couple of years. We've passed legislation, et cetera. What we're going to focus on, we're not focusing this year on prior auths for medications. Maybe that's a mistake. What we're focusing on is trying to curb or even eliminate prior auth and concurrent review for inpatient mental health care. because that's an across-the-board practice. There's no equivalent practice in other medical care. Everyone with diabetes doesn't get a daily review of their inpatient care. We're also going to try to focus on inadequate reimbursement for mental health care, looking at things like out-of-network visits and reimbursement rates for the same services, from mental health to primary care, for example, and present those data and make the argument that these are parity violations and try to see if we can increase reimbursement for mental health care. Wonder if you had thoughts about that, or had considered, is the AMA considering any of those areas for the parity work?
So with parity work, we highlight the issue. As you know, insurance is regulated at the state level. That's why we did that roadmap, and we showed the 4 states. And the person that's been leading on that is the Pennsylvania Insurance Commissioner, number 1. Number 2, you know who has the great tools on this? And is the American Psychiatric Association.
Yep.
They have a great tool for state insurance commissioners to review, because you know what's the document, how, and so APA is really leading on having the tools as appropriate. So our issue, the AMA, again, as Jeff said, we have a platform, we have a bully pulpit to say, hey, do this. We have the resources to fund those 4 states to do that, the resources to do what we did last Monday, which was a national rollout. But I'm very proud, of course, as a psychiatrist, of the work of the APA on that. They've also, so they developed this for insurance commissioners, but they also developed a for patients. So how do patients know? And so the APA has the great tool. So that's who should and does take the lead on that specific work.
Bill?
I wanted to ask you one of those. Does the AMA have a policy on
Yes.
questions? Can the AMA influence to any degree the teaching of substance abuse among medical students? I teach senior medical students in the general hospital, and it is just really striking how little education of any kind, any sense of substance abuse being a part of medicine, other than a problem for the doctor that the patient isn't doing what you tell them.
So the AMA has 2 areas of influence, but certainly one of the issues that we raise, and actually, as you know, you may not know this, but you know, we did this work and we set forth some metrics, some good metrics. We thought, working with the Obama administration, we were first dealing with this issue, and you know, one of the things that he said explicitly, and we say too, this training should start in medical school. So that's our bully pulpit saying that. But then, and you guys can help me, and I was just talking with the dean, you know, about LC, which alphabet, LCME. And I know there's a lot of things required already for medical schools, right? So I still think it's a good idea. The best model is in Massachusetts, Rhode Island. They're doing some great things of teaching and training in medical school. We've got to do it. We agree with that. We highlight that. But of course, the AMA does not have oversight of medical schools. So we can raise the issue and we can provide models. And I will tell you what they're doing at Massachusetts is very good. They're using what's the lab? The simulation lab. And also some great works. They have simulated patients, and then there's a discussion around the patients. And actually what I love about one of their patients is they have an African-American male come in. And so that's an opportunity to talk about so many issues, but our own implicit biases about African-American males, you know, automatically drug seeking. And this gentleman, of course, it's a simulated patient, ends up having a legitimate need for pain and was not drug seeking. So there are models out there. I think it's up to the schools. It's not mandatory, although I think some states did end up probably can't mandate, because the states I don't think have the authority, but of course it may depend on the state. If a state's giving a medical school a lot of money, you know, it may not be in the LCME's list of things you have to do, but a state governor, and I know, some of them did do that. So that's where the AMA has influence, is amplifying it and talking about it and sharing best practices with some medical schools are doing that, but we agree totally.
I just want to ask before we close, what is the AMA's and your particular thinking about the tsunami of digital, mobile, virtual, internet-based adjuncts to healthcare that are all gestating within the private sector now?
another slide that I wish I had, and of course, I can't stay with you all day. I wish I could. I'm having a great time. I love coming to visit New York. So the AMA is absolutely involved in this in several ways. Number one, we founded a company in Silicon Valley, Health 2047, because we said the next generation of technology must absolutely have physician input. And again, putting our money where our mouth is, we have this company, Health 2047 in Silicon Valley. There have been 3 spinoffs. You can look up all the details. We also co-founded another group called Exertia. We have all these mobile apps coming out. Who's regulating these mobile? What should the standards be? What are the guidelines? So we're part of the group that's developing the standards for that. No, that's just this group that we're saying outside, because most of those products are not FDA regulated. Because if you look in the fine print, they say for entertainment purposes only. Yet people think that, oh, I got my so-and-so wearable, and it's telling me exactly, I'm going to send this to my doctor, and then my doctor's going to make decisions. Do we know if that's reliable data? So we are getting in on that. We have a physician innovation network where we match entrepreneurs and physicians. So again, I can go on and on about our work in the physician innovation space. I will tell you one of the things, the spinoffs, one is is called First Mile Care, and I work in pre-diabetes. And we know there's a CDC-based, evidence-based guideline for a diabetes prevention program. Medicare pays for it. Now the commercial insurers pay for it. But again, if you can't have a car, and it was mainly at the Ys of communities, but if you don't have a car to get to the Ys, and it was expensive. I mean, it wasn't thousands of dollars, but I think it was $100. And so we're saying, what if we can push that out to anyone? They can get DPP, Diabetes Prevention Program, on their phone or their iPad. So that was the first spinoff. The second spinoff is a company. It is a Medicare Advantage company, no problem, and we all know we have issues with that. But they are looking at in Chicago, and so they are looking how can they connect their seniors with fresh fruits and vegetables and transportation. So we're very excited, and we're absolutely in that space.
Well, I want to thank you for your leadership, but also just the wonderful representation that you provide for psychiatry and the overall sort of field of medicine. And also what's more as impressive as the work that's doing is just your own command of knowledge of all these different things. So I don't know if it was harder to pass the psychiatry boards or to learn about the agenda and all of the initiatives that the AMA is making. But thank you, and we've got a busy schedule. We hope we don't tire you out, but the next thing is lunch upstairs with residents and some of the faculty.
Very good.
Thank you.
Thank you all very much.